¿Qué tal? Muy buenas noches a todos ustedes. Quiero darles la bienvenida a una sesión internacional más del Colegio de Otorrinolaringología y Cirugía de Cabeza y Cuello Pediátricas de México. En esta ocasión tengo el gusto de hacer un par de anuncios. Uno de ellos, el más importante, es que vamos a dar inicio a un convenio de colaboración con la Asociación Panamericana de Otorrinolaringología y Cirugía de Cabeza y Cuello, a través de su presidenta, la doctora Jacqueline Alvarado, que ha sido presidenta de la Sociedad Venezolana de Otorrinolaringología, ellos otorrinolaringóloga pediatra, y actualmente presidente de la Asociación Panamericana de Otorrinolaringología. Entonces, es un gusto y un honor. La doctora Jacqueline es una excelente amiga y de verdad que siempre está proponiendo proyectos, siempre está proponiendo estrechar los lazos académicos de investigación, de amistad entre los médicos de la Asociación Panamericana, y de verdad es un honor para mí que hayamos podido concretar este proyecto de colaboración académica entre la Asociación Panamericana y COPEME. Jackie, muchísimas gracias y no sé si quieras brindarnos algunas palabras. Después de la doctora Jacqueline, seguiremos con el programa académico.
Bueno, José Luis, muchísimas gracias por la introducción. Y bueno, en la Asociación Panamericana de Otorrinolaringología es un gran honor y estamos muy a gusto iniciar esta unión o partnership con con COPEME, que es el Colegio de Otorrinolaringólogos Pediátricos de México, y que esto estamos seguros que va a impulsar mucho más la educación continua en otorrinolaringología pediátrica, a llenar mucho más, a llegar mucho más alcance a todo nuestro continente americano. Y bueno, y te doy las gracias a ti por como presidente de COPEME, por el gran liderazgo que tienes, la gran apertura que nos lleva a realizar esta unión y que seguro que será muy enriquecedora para todo el público, no solamente de otorrinolaringólogos, pediatras, sino de otorrinos en general sociedades afines como pediatría, laringología, etcétera. Así que, bueno, a disfrutar justamente de iniciar estos lazos y y será creciendo esta unión.
Muchísimas gracias, Jacqueline. Muchísimas gracias nuevamente por hacer posible esta colaboración entre nuestras sociedades y estoy seguro que será muy fructífera. Te agradezco nuevamente y bueno, seguiremos con el programa académico. A continuación, el doctor Carlos de la Torre será el coordinador general de esta sesión. El doctor Carlos de la Torre es conocido de todos nosotros, fue presidente de COPEME, actualmente está en la Junta de Gobierno del Consejo Mexicano de Otorrinolaringología. El doctor Carlos de la Torre es jefe de servicio y profesor titular de la subespecialidad en otorrinolaringología pediátrica en el Hospital Infantil de México. Y bueno, pues me echaré a otra media hora hablando de su currículum. Doctor Carlos de la Torre, siempre es un gusto. Y antes de iniciar con la parte académica, sí quisiera tomar unos segundos para agradecer a los laboratorios Armstrong que se unen como sponsors, como patrocinadores de las sesiones internacionales. Eh, y la verdad es que nos da mucho gusto contar con su apoyo. Siempre es un gusto que la gente de la industria crea y nos tenga confianza en el proyecto que estamos encabezando con COPEME, que si bien tiene poquitos años, pues le hemos echado muchas ganas para ir creciendo la oferta académica, la calidad de las sesiones, y les agradecemos muchísimo su apoyo, la confianza y que sean parte de nuestros patrocinadores. Entonces, muchas gracias al laboratorio Armstrong y los dejo con el doctor Carlos de la Torre, quien va a presentar a todos los profesores. Muy buenas noches a todos ustedes.
Buenas noches, muchas gracias al doctor José Luis Mayorga, nuestro actual presidente del Colegio de Otorrinolaringología y Cirugía de Cabeza y Cuello Pediátricas de México. Sin duda alguna, pues hoy es un día memorable para este colegio, porque pues nos enlazamos con la Asociación Panamericana de Otorrinolaringología, dirigida por una extraordinaria otorrino y excelente amiga, que es la doctora Jacqueline Alvarado, y qué mejor que inauguremos estos lazos con la Asociación Panamericana con un ponente de la más alta calidad. Nos referimos al doctor Albert Park, de quien hemos tenido la oportunidad de escuchar pláticas, la última que tuvimos el agrado de aprender muchos conceptos y que seguramente ahora nos los va a transmitir en la Academia Americana de Otorrinolaringología el año pasado. Y bueno, hablar del currículum del doctor Park sería pues prácticamente la sesión. Simplemente yo quiero dar algunos datos que son muy importantes para ubicarnos, porque uno de sus líneas de investigación y de sus temas favoritos es precisamente el que se va a presentar el día de hoy. Entonces, el doctor Park es el jefe del servicio de otorrino pediátrica en la Universidad de Utah y del Hospital Pediátrico Primary, y entre otras cosas supervisa las operaciones de 8 médicos becarios en otorrinopediátrica y ha tenido el privilegio de tratar a niños durante más de 15 años en el Hospital Pediátrico Primary. Nació en Baltimore, Maryland y creció en New Jersey y estudió en Swarthmore College y luego se mudó a San Luis para obtener el título de médico en la Universidad de Washington. Terminó su residencia en otorrino en el Centro Médico de la Universidad de Loyola en Chicago y su especialización en otorrino pediátrica en el Hospital de Niños de Toronto, Canadá. Se incorporó al profesorado del Centro Médico de la Universidad de Loyola en Chicago durante 7 años y en agosto del 2002 se trasladó a Salt Lake City para convertirse en profesor asociado de la Universidad de Utah. Actualmente es profesor y otorrino pediatra, especialista en otorrinolaringología en la Universidad de Utah y en el Hospital Pediátrico Primary. Es el investigador principal de un ensayo clínico multiinstitucional financiado por institutos nacionales de salud en los Estados Unidos para determinar si el medicamento antiviral Valganciclovir puede mejorar la audición en los niños con CMV, que es una causa más muy común, como ustedes van a poder apreciar, y poco estudiada de pérdida auditiva infantil. Ha colaborado, ha tenido esfuerzos de colaboración que han dado como resultado el primer análisis de PCR clínicamente validado en sangre seca y saliva para detectar la infección congénita por CMV en niños. Colaboró también con el representante Menlop y otros para presentar un proyecto de ley en la legislatura de Utah con el fin de aumentar la concientización general sobre la infección congénita por CMV y exigir la prueba temprana en recién nacidos que no superan la prueba de audición. Esta legislación se aprobó en julio del 2013 y Utah se convirtió en el primer estado de la Unión Americana en implementar un programa de detección auditiva para el diagnóstico temprano de CMV. Ha formado parte de la sección de estudios en otología de la Academia Americana de Otorrinolaringología y ha sido revisor de los Institutos Nacionales de Salud y ha formado parte de varios comités de programas de la Academia Americana de Otorrinolaringología, de la Sociedad Teológica y también del ASPO, de la Asociación de Otorrinopediátrica de los Estados Unidos. Fue presidente del Comité de Investigación de la Sociedad Americana de Otorrinopediátrica y creó la red de CMB del ASPO para impulsar estudios clínicos pediátricos multiinstitucionales. Es miembro de la Junta Directiva de la Fundación Nacional del CMB, la única organización nacional creada para informar y educar sobre medidas de prevención específicas para protegerse del riesgo de contraer CMV. Ha impartido conferencias en muchas regiones, Estados Unidos, Europa y Asia, sobre una amplia gama de temas relacionados con la otorrinopediátrica y la audición. Es autor de más de 100 artículos en revistas y capítulos de libros y disfruta enormemente impartiendo clases a estudiantes de pregrado, medicina, residentes y becarios. Lleva más de 20 años casado, tiene 2 hijos maravillosos y 2 perros maravillosos también. Le gusta nadar y participa en los triatlón. Entonces, como ustedes pueden ver, pues el currículum del doctor Park, pues habla por sí solo y seguramente va a darnos mucha información de gran importancia para los otorrinolaringólogos que estamos conectados en este momento. Yo sugerí al doctor José Luis Mayorga que tuviéramos la participación en la coordinación de un infectólogo y un genetista para que aportaran conocimientos, sobre todo en el área de México, y de esta manera se enriqueciera la sesión. Para ello, le pedí y le agradezco mucho a la doctora Verónica Fabiola Morán Barroso, que participará con nosotros. La doctora Morán es jefa del Servicio de Genética del Hospital General de México, Eduardo Lisiaga. Es doctora en genética por la Universidad de Edimburgo, Escocia, en el Reino Unido. Es profesora titular de pregrado y posgrado en genética de la Universidad Nacional Autónoma de México, expresidenta del Consejo Mexicano de Genética, vicepresidenta de la Asociación Mexicana de Genética Humana, miembro de la Academia Mexicana de Pediatría y miembro del Sistema Nacional de Investigadores con nivel 2. Y por la parte de infectología, va a participar con nosotros el doctor Rodolfo Norberto Jiménez Juárez, quien actualmente es el jefe de infectología del Hospital Infantil de México, Federico Gómez, y ha tenido una gran trayectoria tanto en foros nacionales como internacionales, tanto en pediatría como infectología, como profesor, como investigador y también en programas de educación médica continua. Su trayectoria data de más de 15 años, tanto a nivel institucional como privado, y por supuesto que ha realizado múltiples estudios y, por supuesto, una labor asistencial, sobre todo en pacientes recién nacidos. Tiene una práctica privada actualmente en Star Médica Hospital Infantil Privado y en Grupo Ángeles. Entonces, sin más detalles, entonces procederemos a darle la palabra a la doctora Verónica Morán para que nos dé una breve semblanza de lo que sería la genética de la hipoacusia y sobre todo la importancia que tiene el tema para todos los otorrinolaringólogos y particularmente los otorrinos pediatras y posteriormente el doctor Jiménez nos hablará sobre ciertos aspectos y baches o brechas que nos quedan todavía por resolver en cuanto a este tema que vamos a analizar el día de hoy. Y más adelante nuestro platillo fuerte es la presentación del doctor Albert Park con uno de sus temas favoritos que es la hipoacusia congénita de origen no genético, particularmente causado por CMR. Sin más preámbulos, damos la palabra a la doctora Verónica Morán para que nos haga una introducción de su área.
Muchísimas gracias, buenas noches a todos. Agradezco en primer lugar la invitación del COPEME, muchísimas gracias, es un honor para mí participar con ustedes. Creo que ahí podemos verlas. Como les decía, muchísimas gracias por la invitación. De manera muy breve voy a comentar con ustedes acerca de las causas genéticas en relación con la hipoacusia. Como ustedes saben y son expertos, es una de las alteraciones congénitas más frecuentes, afecta de 1 a 2 en cada 1000 recién nacidos y hay varias clasificaciones que pueden ser por sus sitios anatómicos, por la edad de presentación o su gravedad, etcétera. Y uno de los puntos importantes es acerca de su etiología, que podríamos decir en términos muy generales que se trata de una etiología genética o no genética. Otro de los puntos importantes aquí es en esta etiología, si nos enfocamos a las causas en diferentes publicaciones y revisiones recientes, se habla de que puede ser del 20 al 40% de los casos adquirida, que ya se tomará este punto, y en el 60 al 80% puede ser por causas genéticas. De estas, el 30% serían sindrómicas, con más de 600 síndromes descritos, y el 70% serían no sindrómicas, es decir, que consideramos que tiene una presentación aislada, de las cuales cuando nos referimos a alteraciones monogénicas y pensamos en los patrones de herencia, hablamos sobre todo que lo más frecuente es en relación a una presentación autosómica recesiva en el 80% de los casos, seguida por una situación autosómica dominante en 15 al 20%, 2 al 5% ligado al X y 1% de origen con variantes patogénicas mitocondriales. Es importante mencionar que algunas publicaciones consideran que del 20 al 50% hay un gen en especial, que es GJB2, que está presente en diversas poblaciones. Uno de los puntos importantes de la investigación acerca de los genes es acerca de la variabilidad que hay en la presentación clínica. En esta revisión de una de las páginas que se dedica a revisar el número de genes identificados hasta la fecha, que se revisó hace un par de días y que fue revisada a su vez en febrero, nos identifica aproximadamente 156 genes relacionados con la presentación de la hipoacusia. Es interesante el conocer esta información por muchos motivos, entre otros, es lo que llamamos la correlación del fenotipo, que es la manifestación clínica de estas alteraciones, con el genotipo, que es de lo que nos habla acerca de las funciones de las proteínas codificadas por estos genes, como por ejemplo en relación a los electrolitos o a neuropatías auditivas o alteraciones del citoesqueleto, por mencionarles algunas de manera general. En este sentido, las técnicas y la ciencia en relación a las pruebas y a los análisis genéticos ha presentado un gran progreso en las últimas décadas y se ha ido de la posibilidad de analizar un solo gen, digamos, cuando tenemos una sospecha o tendríamos una sospecha en particular, a realizar secuenciación masiva en paralelo o secuenciación llamada también de nueva generación. Aquí lo que nos permite esto es analizar una gran cantidad de genes e incluso todo el exoma, que recordarán ustedes que son los genes que están identificados como codificantes de proteínas, y en algunos casos muy particulares la revisión de todo el genoma. Estas técnicas son un reto porque nos permiten analizar en base a la sospecha diagnóstica qué es lo que queremos nosotros revisar en cuanto a la enfermedad que tenemos, si es aislada, si es sindrómica, y cómo debemos de seguir este camino para poder explicar la presentación de la enfermedad de nuestros pacientes. La clínica siempre será lo más importante. En el caso, por ejemplo, de que consideremos una etiología genética, están los antecedentes heredofamiliares, por supuesto, todo el proceso que es el asesoramiento genético, y como verán ustedes en este flujograma, en donde tenemos en consideración tanto la parte que podríamos considerar que es una alteración aislada como una situación genética y que sospechamos un síndrome, como les decía, podríamos utilizar esta tecnología para revisar diferentes genes, para revisar el exoma o para revisar el genoma. En México hay algunas publicaciones con relación a la identificación de variantes patogénicas o mutaciones en pacientes que presentan esta pérdida auditiva congénita. Esta, por ejemplo, del 2021 se realizó una revisión hasta ese momento de las publicaciones y lo que se encontró es que, por supuesto, como en otras regiones del mundo, es muy importante el gen GJB2, pero también tenemos algunos otros como sería el SLC26A4, y además una de las aportaciones es que estas revisiones se hicieron en diferentes poblaciones en nuestro país, lo que también refleja esta variabilidad que puede presentarse con respecto a las causas genéticas. El análisis genético nos permite entonces en un porcentaje identificar la causa de la hipoacusia, y esto especialmente en relación al diagnóstico, sobre todo si consideramos que pudiera haber alguna historia familiar. Y si no tenemos un paciente con historia familiar de pérdida auditiva y no hay una etiología clara, podríamos considerar la posibilidad de que se presente un síndrome, y esto es muy importante porque tendría consecuencias para un manejo temprano, con una intervención temprana y apoyar en su desarrollo. Además, hay síndromes que cursan con pérdida auditiva perlingual y no son clínicamente, fenotípicamente descritos en el recién nacido, y se llaman aquellos que son non-syndromic mix, que serían similares a lo que sería una hipoacusia considerada de forma aislada. Y esto es interesante porque nuestra población en México, en esta publicación de Rodríguez Valero en el 2024, se analizó a 30 pacientes que tenían pérdida auditiva a través de exoma y paneles de genes, y como ustedes verán, pues fue identificada una causa genética en 47% de ellos. 7% de ellos tuvieron un resultado inconcluso, que es cuando nos referimos, por ejemplo, a variantes o cambios en la secuencia que todavía no sabemos cuál sería, si están relacionados o no con enfermedad. Pero lo que es muy importante es que en este grupo de pacientes que estos autores revisaron, si bien fueron referidos por la hipoacusia, lo que sí se encontró es que un alto porcentaje de ellos tenía una forma sindrómica de pérdida auditiva similar a la pérdida auditiva no sindrómica en edades tempranas, y que no podría descartarse sin un estudio genético. Esto es en relación a la importancia de contar con ese asesoramiento genético. Como consideraciones finales y en esta muy breve semblanza de lo que sería la parte genética, tendríamos que considerar en nuestros pacientes la alteración aislada versus una entidad sindrómica. Para ello es importante, por supuesto, la historia clínica y los antecedentes heredofamiliares, considerar el asesoramiento genético, y de ser el caso, tenemos una variedad de pruebas moleculares y de abordajes, pero consideraría yo que lo más importante es lo que es reflejo de esta sesión, que es en relación al manejo interdisciplinario interdisciplinario, multidisciplinario, porque es una responsabilidad compartida de todos nosotros el poder ofrecer a nuestros pacientes este abordaje y en un momento dado determinar cuáles serían los mejores análisis para ellos, para, en el caso de los genetistas, ofrecer este asesoramiento genético y este manejo interdisciplinario junto con ustedes. Les agradezco mucho su atención.
Buenas noches. Yo no voy a, soy el doctor Rodolfo Jiménez. Yo no voy a prender la cámara porque tengo problemas de conectividad, pero a mí me toca hablarles un poquito acerca de la parte de citomegalovirus como causa de una hipoacusia. Bueno, principalmente, bueno, voy a empezar a compartir. Son 4 slides nada más en este sentido para escuchar a nuestro invitado. Y en este sentido, lo que creo que vale la pena de decir en esta primera semblanza es que el citomegalovirus es un virus ubicuo, es un virus que es decir, todos vamos a estar seropositivos en algún momento en la vida, casi siempre, sobre todo en hospitales, perdón, en comunidades en vías de desarrollo. La infección en madres o en mujeres en edad reproductiva es muy diferente en este sentido. De lo importante del citomegalovirus es que tenemos que recordar que se transmite por la saliva, pero también puede ser transmitido por vía congénita. Y aquí en este diagrama lo más importante no es ver qué es diferente en países de primer mundo y en países en vías de desarrollo. Por ejemplo, en México y en países latinoamericanos generalmente se considera que el 90% de las mujeres en edad reproductiva son inmunes y solamente el 10% es no inmune. Y de ellos son los que van a tener posibilidad de transmitir la infección al recién nacido si es que se infectan en el embarazo, que es cuando tienen mayor riesgo, 1 a 5%. Ahí la infección fetal va a tener más o menos un 50% y el 30% va a ser sintomático, pero lo más importante es esta parte, 90% en países en vías de desarrollo ya son inmunes las mujeres, tienen muchísimo menos riesgo de transmitirlo en forma global. En cambio, en países de primer mundo apenas el 50% son inmunes, entonces en la prima infección es cuando tienen mayor posibilidad. La otra situación es que tenemos que tener claro que es parte del complejo de las infecciones de transmisión perinatal, el citomegalovirus. Y en esta pirámide en donde tenemos a la mayoría es la infección materna no diagnosticada, ya sea una infección materna previa o una infección aguda. La gran brecha es que no buscamos intencionalmente a recién nacidos infectados. Afortunadamente ya hacemos tamiz auditivo, pero dentro de los que tenemos tamiz auditivo que no pasa, deberíamos de estar buscando como una de las causas las infecciosas. Y esos ya que no pasan el tamiz auditivo quedarían en el piquito, que son los bueno, estarían como asintomáticos y muy poquitos quedarían como la parte de los sintomáticos. Una de las grandes brechas o en la parte del conocimiento es a qué pacientes tendríamos que tratarlo. Tenemos opción de tratamientos contra citomegalovirus, pero y en ese sentido, tradicionalmente, las infecciones que ponen en riesgo la vida, como esas encefalitis, neumonitis, púrpuras, hepatitis, son los que generalmente se tratan. Sin embargo, ya se verá en esta sesión, también hay beneficio de tratar a los pacientes que solamente tienen hipoacusia o alteraciones del sistema nervioso central en este sentido. No voy a decir más para dar pie a la discusión en este sentido. Y la otra gran brecha que existe es a dónde vamos a mandar el diagnóstico. Estas son las diferentes estrategias diagnósticas. Para la mamá, la forma de diagnosticarlo y que le toca a nuestros colegas em, obstetras es la parte serológica. Pero cuando queremos diagnosticar infección congénita por CMV, primero para que la diagnostiquemos como congénita, la tenemos que hacer en las primeras 3 semanas por una situación de consenso de definición. Segunda, las detecciones de antígeno en su momento no eran tan sencillas, ahorita eso ya pasó, y actualmente la biología molecular es la que realmente es el estándar de oro. Ahora, el detalle es, sobre todo en las brechas en lugares en vías de desarrollo, es cómo hago llegar la muestra. Entonces, la mejor opción Para esas muestras es en papel filtro, así como se toma el tamiz metabólico, también se puede hacer el diagnóstico del citomegalovirus en papel filtro en este sentido. Yo creo que también es parte de lo que seguramente nos va a hablar el doctor Park. Y en este sentido, yo como último mensaje quisiera dejarles que tenemos que pensar en citomegalovirus como causa de sordera, que la parte interdisciplinaria de esta sesión, en donde empieza con el obstetra, sigue con la parte del tamizaje auditivo por parte del lugar de nacimiento y posteriormente sigue con el diagnóstico etiológico de la causa de la sordera para ver qué alternativas de manejo vamos a llegar a tener y la interprofesionalización creo que es algo que le puede beneficiar sumamente a los pacientes, sobre todo a los más complejos, y es algo en lo que tenemos que trabajar en México. Y pues, sin más por esto, yo creo que estaríamos para darle la palabra al doctor Park y poder disfrutar de, de toda su conferencia. Muchas gracias.
Hopefully you can hear me, and I thank everybody for this invitation. It's really quite an honor to be presenting to you, and really also appreciate these outstanding lectures that have already been given on the genetics aspects as well as on cytomegalovirus. So I'll go ahead and share my slides so you can see these. So what I thought I would do is talk about the sort of current status of congenital CNV in the context of our practices. Those of you who see children with hearing loss, I think this is very pertinent, and also how it integrates with the other testing, such as the genetic testing that's been presented earlier. For disclosures, I do have some funding. I also am a consultant for CUOS. I don't think any of these relationships are relevant to this presentation. I do, though, want to mention that I will be talking about the antiviral medications valganciclovir and ganciclovir, which are off-label uses for this condition. But there is a number of studies that I think have demonstrated efficacy and safety. And so I will be talking about these medications in this presentation. So I thought what I would really concentrate on is maybe expand a little bit about the prior presentation on cytomegalovirus in terms of its importance, talk about the current status of diagnosis and treatment, and then present to you sort of our story in Utah, how this early CNV testing was implemented, the rationale for this, and some changes over the years that we have implemented in our state, and then how this compares to universal dry blood spot CNV screening, which has become an important also alternative way of identifying these children, and then maybe some recommendations that maybe we in Mexico might want to consider incorporating into your practice. So I thought I would start though with the families. I think the families are our greatest ability to learn about this condition. This is the reason for why we do what we do. And they're great spokespeople for their children and for their families. And so I thought I would share this little bit of information from Caitlin Hill. I want to thank the family for agreeing to share this to tell you a little bit about their perspective. So let's talk a little bit about CMV itself. And again, I want to thank Dr. Juarez for the presentation, but I was going to add a little bit to that. So as we all know, it's a herpes virus. It is the most common congenital infection worldwide. It is really not a problem when you develop this infection as a toddler, as a newborn, but really it's an in utero infection that really comes to our attention in terms of the hearing loss. It's a very important cause of neurodevelopmental delay. And in terms of the overall uh, prevalence of pediatric, especially congenital sensory hearing loss, and maybe even later in terms of acquired, it accounts for up to a quarter of these sensory hearing loss patients. The transmission is believed to be typically in utero, where you have in the United States, in many cases, we have a relatively high seronegative rate. In Mexico, it's as was mentioned earlier, it's about 90% seropositivity, and so secondary infection tends to be the driver of transmission in Mexico. There's a much higher transmission rate in those who are seronegative. It's 30 to 40% or so. A much lower rate for non-primary or secondary infection, but still exists. And in fact, in Mexico or in other developing countries, is the major driver for infection in these children. It's believed that maybe reinfection or reactivation may be part of the sort of pathway or mechanism for non-primary infection. And again, in many cases in the developing world, non-primary infection or those who are mothers who are seropositive, that accounts for many of these infections in these locations. Now, there's sort of been a sort of evolving way of defining congenital CMV. The historical has been using terms such as asymptomatic and symptomatic. But recently, Stephanie McVicker had come together with a number of other infectious disease otolaryngologists, as well as other healthcare providers, to come up with a different sort of case definition. It's more for epidemiological reasons, but I think it's also very useful for us clinicians in terms of trying to define this a little bit more precisely. The challenge with looking at symptomatic is that people use different definitions for symptomatic or asymptomatic, and that's unfortunately caused a bit of confusion in the field. So this is why our AAP, we have a position statement that hopefully will be coming out in the next few months. We have recommended using this different definition. And so in terms of congenital CMV, we define it as disease. That accounts for probably 10 to 15% of these cases. Unfortunately, it can result in fetal demise and prematurity. And these children often present with sensory hearing loss, abnormal imaging, abnormal transaminase or CBC results, as well as a host of other signs and symptoms. This is sort of the classic presentation of a child with disseminated petechiae, which you can see on the face. You may also have a child who, this is an axial CT scan where you're seeing some evidence of calcifications, which is very characteristic for this condition. Now, that is in contrast to CMV infection. And so that's a laboratory sort of definition. This accounts actually for the majority of children with congenital CMV. In these cases, these children do not present with any obvious signs or symptoms. They have normal central nervous system imaging. They have normal diagnostic hearing testing, normal blood tests. So this is the majority of children who present in this manner. But I think this sort of definition of defining as a congenital CMV infection or CMV disease, I think provides a little bit more clarity and hopefully can be standardized across the field. Now, how do you make the diagnosis? Was, as mentioned earlier, the best time to do it is early. And so typically we want to diagnose these children within the first few weeks of life. Postnatal infection is not associated with hearing loss. And so you want to be able to exclude a postnatal acquired infection from a congenital infection. And in terms of how you diagnose this, typically, you'll want to obtain a culture or PCR, either of urine or saliva, though you have to be careful about saliva because of breast milk contamination. And another option is using neonatal dry blood spots, which I'll talk about in just a moment. Now, in terms of saliva, there have been a number of studies, but I think two that I want to bring to your attention or were relatively large studies that showed about a 26 to 41% false positive rate with saliva testing. This is probably due to breast milk contamination. And so if you have a child who you test using saliva, you really need to obtain a confirmatory urine before the child is 3 weeks to establish a diagnosis. And this has come up in my practice where a number of children have had a positive saliva test, were actually placed on antivirals, and then when they came to see us in our multidisciplinary CMV clinic, we obtained a urine that was negative. And so, unfortunately, a number of these children were treated with antiviral therapy when they really shouldn't because they did not have a congenital CMV infection. The other alternative is just to get a urine, and I'd say in Utah, I'd say well over 90% of children who are tested for congenital CMV infection undergo a urine rather than a saliva test. Now, what about neonatal dry blood spot? Two major papers have come out over the years. First one was by Suresh Papama at University of Alabama. It was a multi-institutional study called the CHIME study, and essentially they compared saliva cultures to dry blood spot, and they found a relatively they found 92 of the 20,000 children tested with a positive sample, and then they obtained dry blood spot testing. Unfortunately, they found that the sensitivity when you compare it to saliva rapid culture was only 34%. And so this was a major blow to the field because the thought at that time was that maybe dry blood spot testing could be used on a mass scale for screening and really set back the field. But then more recently, Mark Slice at Minnesota and Sheila Dollard did a very large study in Minnesota. This is the results from their JAMA paper. It was an interim analysis, but they found a much higher sensitivity, excuse me, of about 75% and excellent specificity with dry blood spot. So that sort of changed the outlook where before we were thinking maybe dry blood spot really could not be used on a mass scale. Now, this provided, I think, the rationale, and that's why I think Minnesota has been able to implement universal dry blood spot screening in their state, and a number of other states, such as Connecticut, and others are looking at this as a possible option. And I'll talk about the pros and cons of universal dry blood spot, especially in relation to what we do in Utah. Now, why do we do this? Well, one of the reasons is that if we can identify those children who are at risk for progressively worsening hearing, that maybe we can treat them with an antiviral medication such as ganciclovir or valganciclovir. Valganciclovir is a prodrug form of ganciclovir. The nice thing about valganciclovir is that you can administer that orally. It's believed to work by inhibition of viral replication. Now, technically, it is not FDA approved. It is FDA approved for those who are receiving kidney or heart transplants. But there have been a number of studies. I say one of the major, most influential ones is by David Kimberlin's group, published in the New England Journal of Medicine in 2015, that showed that if you compared 6 months for 6 weeks of antiviral therapy, that children with severe, this is children with severe disease, that the children who were treated for 6 months had better hearing outcomes. They also looked at neurocognitive outcomes too, specifically looking at language scores, and they found improvements in 6 months over 6 weeks in those categories. Now, my sort of story of CMV and my interest really started probably in the early 2000 period when I happened to go to a national conference in Washington, D.C. and met Amy Donahue, who at the time was the interim director of the NIDCD. And when I met her, she was lamenting the fact that there's been very little work being done on CMV. And although I've heard about it, I think all of us in training learn about it as residents and such, but I had rarely seen it. I probably saw maybe 1 or 2 children over a year with this condition. And so I started to become interested. I started reaching out to a number of experts around the country. I contacted Mark Slice, who I cited some of his work earlier in this talk. I also reached out to David Hilliard, who is the medical director for the Molecular Infectious Disease arm of ARUP, which is a national reference laboratory in Utah, which really specializes in development of diagnostic testing. And so through these collaborations, we developed a saliva assay as well as a dry blood spot assay that is CLIA validated that would enable us to identify children with congenital CMV. Because really, there's not much you can do unless you have a good sort of diagnostic test for you to be able to identify these children. Now, I do want to go back to, I think, Dr. Moran, who had presented some of the genetic aspects of congenital hearing loss. I want to go back to a slide that's similar to hers, and this is from Elliot Shearer, who presented this at our Academy meeting just last year. But really to highlight the importance of genetic causes of hearing loss, but also not to, I think still it's important to consider environmental, including that with congenital CMV as causes. And this just shows the breakdown, which was shown earlier about syndromic and non-syndromic. And she had emphasized, and I completely agree, that a multidisciplinary approach to children with congenital hearing loss is really important. That's what we have in Utah, where we have a hearing center that includes a geneticist, genetic counselor, speech and language pathologist, audiologists, and myself, who see families together so that we can then provide really direction for the families in terms of determining the cause, as well as provide resources. And as mentioned earlier, there's quite a few genes that have been known to account for congenital hearing loss. Now, as I kind of alluded to earlier, back in 2006 or so, when I became interested in cytomegalovirus, I also became interested in how do we incorporate this sort of test in the sort of general scheme when a child presents to you with hearing loss. And really through up to 2012 or so, this is sort of the algorithm that was adopted, where you obtain a history, physical examination, perform an audiologic workup, but then at that stage, then you start thinking about genetic testing or maybe imaging, especially if there's a unilateral loss. Those are sort of the recommendations, and CMV testing really was not even discussed as a potential test for these children. And so around 2011, 2012 or so, I became interested in maybe incorporating CMV testing. And because CMV testing needs to be performed in the first 2 weeks of life so that you don't are not confounded by postnatal infection, my recommendation and thought was maybe we should incorporate CMV testing really early in that process so that we don't, again, have problems with distinguish this from postnatal infection, even earlier than genetic testing or imaging. And so we did a study starting around the late 2000s or so. This was in our multidisciplinary clinic. And what we found was that if you incorporated CMV testing, that a large portion of children, especially in this clinic, were found to have this as a cause. We also looked at cost considerations, and we found that in blue is those who underwent CMV testing first. The y-axis shows you the cost per 100 children, and this is regardless of the degree or severity of hearing loss, which is shown in the x-axis. That the blue curve, which represents CMV testing first, was the lowest, regardless of the type of hearing loss or regardless of the type of testing that is other tests that are done. Green would show if genetic testing was done first, red is if imaging was done, and purple would be if all simultaneous testing, which would be the highest cost. The only exception is those with ANSD conditions, where imaging seemed to be more cost effective than CMV testing. Around this time is when I also was introduced to Didi, who at that time was 19 months of age. She came to me because she had a history of failed newborn hearing screening, had a mild hearing loss on click ABR testing, but really people had just recommended surveillance, and I don't think anybody really thought much of this. But by the time she had seen me at 18 months of age, she now developed a profound hearing loss in the right ear and a moderate sense of hearing loss. Because of my collaboration with David Hilliard at ARUP, we had saliva CMV PCR testing as well as neonatal dry blood spot testing available. So we ran those tests, and these came back as positive. And so we were able to establish a diagnosis of this child for this condition. We treated them with antivirals. At this time, this was around 2012. There wasn't a lot of data. The New England Journal of Medicine paper had not come out, but we felt that it'd be worthwhile to see if we can prevent further progression. But unfortunately, her hearing in that left ear worsened to the point that she required cochlear implantation. Now, DD actually turned out to be the granddaughter of the former state representative Rhonda Menlove, who was very active in child and maternal health care issues in the state of Utah. And her mother is Sarah Dutray, who in the future became a board member of the National CNV Foundation and has currently been very active in CNV related issues to this day. And so it's interesting, during this time when I was learning about CNV and realized the importance of this both for a clinical practice as well as the public health implications, not much was really happening in our state. But once DD was diagnosed, immediately Representative Menlove sort of developed a coalition of a number of providers, members of the Utah Department of Health and Human Services, insurance, families together. And we met and we discussed all these sort of issues. And one of the things that we discussed was the complexity of diagnosing the older child for congenital CNV. And that's kind of shown in this figure to your left, where if you have a child who presents with sensory hair loss, who's over 3 weeks of age, it's quite complex in terms of how do you be able to diagnose these children, a lot of time relying on dry blood spot sampling testing, which isn't always available, at least in the United States. There's quite a bit of variability in those states in terms of how long they keep the neonatal filter paper for testing. And we discussed newborn hearing screening because in Utah and many other places throughout the United States, universal newborn hearing screening has been very effective. We are able to identify those children with sensory hearing loss. And the thought was that if we sort of piggybacked onto an existing successful program, we realized it's not perfect, but that we would identify many children who are at risk to have hearing loss from congenital CNV. And so the algorithm was that a child would have a newborn hearing screening, would be tested. If they were found to not pass, then they would undergo CNV testing, and then that would then be incorporated into the workup, especially for those children with congenital hearing loss. We also discussed the issue of its impact, because if you compare CNV to those with fetal alcohol syndrome, Down syndrome, spina bifida, or other conditions, CNV is actually much more common than those. And yet, if you look at maternal awareness of these diseases, CNV comes in last. In many studies, about 10% of moms are even aware of congenital CNV. So there's a real big problem with messaging, with awareness, and yet it's a very common and at times very devastating condition. And so with this conversation that Rhonda had with all of us, we came up with these sort of recommendations, and this was introduced as a bill to the House of Representatives back in the fall of 2012, spring of 2013. And that was that we would try to address the lack of awareness, and this would be accomplished by the Department of Health and Human Services, also provide education to providers and other organizations that offer childhood services, and then also to incorporate some sort of screening or testing, where any child who's found to fail, we used the recommendation of 2 failed newborn screening tests, that those children would be screened for congenital CNV, and that we would discuss these results and their ramifications with the families. And this really was a team effort. Carl White, who is the founder of the National Center for Hearing Assessment and Management, very involved in EDI and early hearing loss issues. Jim Bale, who really was an early pioneer in CNV research, a pediatric neurologist and colleague, really worked with the Rhonda Menlove, with the insurance companies, and multiple presentations to the legislative sessions. And really almost unanimously, this legislation got passed. And this is actually a picture showing this signing ceremony, where at that time, Governor Herbert signed the legislation, as shown in this figure on the bottom. And then the key players such as Rhonda Menlove, Sarah Dutray, and then Daisy Dutray pictured here. And then there's a picture of me here in the background. So again, Utah became the first state in 2013 to implement early CNV testing. And almost immediately, we had a lot of negative pushback, especially from the American Academy of Pediatrics. This is a publication that they come out with. This was from the Department of Practice and Division of Quality, responding to our legislation. And they stated that clinicians that are practicing the best, most up-to-date fashion faced increased medical practice liability risk from this legislation, and that if states continue down this path, it may threaten our ability to practice medicine, excuse me, in a manner that's consistent with the best available science. So certainly this was a very controversial issue, and there were a number of very prominent physicians who really opposed to this direction. And yet, I think what we've found over the years through our publications and evidence-based research, that actually it's been a very beneficial approach. And in fact, this is a paper that came out about 3 years after the state legislation in Utah was passed by Lemming et al. This is a group of pediatric otolaryngologists. And what I wanted to highlight here is that where before either genetic testing or imaging was recommended first, in this algorithm, CMV testing is recommended first. Again, because the need for timely diagnostic testing and the importance of not missing or failing to identify these children. And then in terms of nationally, as shown in yellow are the states that have implemented some sort of early CMV targeted hearing testing. And then red is the Minnesota group. New York had a contract with NIH to study universal dry blood spot screening. And then Connecticut has also implemented legislation to start universal dry blood spot screening. So there's been really, over the years, quite a bit of activity. And really, it's been gratifying to see that a number of states have implemented some sort of early CMV testing. Though, as you can see, there's still many states that haven't, and there's a lot that needs to be done. Now, how are we doing? This is just an example of the typical child that I see now in my practice. This is a 36-day-old infant who presented to my clinic. They failed their newborn hearing screening, both in the hospital, and then they will typically then be seen by a audiologist about a week or so after discharge. They undergo, again, repeated testing, and that child failed again. And so that child then underwent urine CMV PCR testing, which was positive, and then had imaging as part of the workup because we want to then determine the severity of the CMV. We want to determine if there's any central nervous system abnormalities. Fortunately, the MRI was normal, had a diagnostic hearing testing. Unfortunately, was found to have a left severe to profound hearing loss, was treated with antiviral therapy. But now the child is 10 years or so of age. It's done very well with no progressive or worsening in that right ear. I think if this child presented now, we would recommend a cochlear implant, but at that time, which was about 10 or so years ago, the child was offered a cross instead. Doesn't require speech and language therapy, is doing well in school, and continue to have surveillance hearing testing. And so this is sort of the gratifying sort of results of the legislation, is that this is just part of my practice, that every child who comes to see me who has a congenital sensory hearing loss will have already had CMV testing before I even see them, that it's all just part of the statewide algorithm that's happening. And so over the last, say, 15 or so years, we've identified about 250 children with congenital CMV. We have a multidisciplinary CMV clinic, as shown the different players. We have monthly meetings with the Utah Department of Health and Human Services, and we've identified a number of children with central nervous system abnormalities. A number have been treated with antivirals, and we've identified these children with their hearing loss. Now, in terms of other aspects that we have seen from this state legislation, this is a paper that was published in Pediatrics, where we looked at the time of diagnostic hearing testing. The recommendation nationally is that we want to have children undergo timely diagnostic testing by 3 months of age if they failed their newborn screening. 2 years before the legislation, about 55% of those children actually had that timely diagnostic testing. And then 2 years after the legislation, you can see that there was a marked increase of almost 80% of children who underwent diagnostic timely testing. And then if you actually look at those who underwent CMV screening, they also, almost 90% of those children had timely diagnostic testing. Now, the benefit of this is not only for the children with congenital CMV, but this actually then benefits all children who fail newborn screening, because all these children are getting earlier diagnostic testing. And so that's what we've found. And why is this important? Well, there's an important paper by Christy Yoshinaga Itano, which was published back in the late 1990s, that demonstrated that if you identify and treat a child with congenital hearing loss before 6 months of age, these children do better in terms of language outcome measures compared to those children who are identified and treated after 6 months of age. And this is really what drove the universal newborn hearing screening, as well as this is what drives all of us in the hearing field in terms of wanting to provide timely intervention and treatment. Now, this was really, again, very gratifying that we were identifying children, but we also felt, and this was following a Grand Rounds presentation in 2016, that we still had a lot more that needed to be done. We felt that we were not really identifying a lot of the children with more severe disease, and so we assembled a group of a number of different providers. We met monthly to try to determine how can we do better with hearing targeted screening. There's a number of papers that are out there, a lot of them from Soren Gantz's group, that show that less than 10% of children with severe congenital CMV are being identified based on clinical suspicion. And we felt that many of the children, even through hearing targeted, were not being identified. And these are the children that we definitely want to identify because the studies have shown that they're the ones that are most likely to benefit with antiviral therapy. And so we came up with these various about 11 criteria that we thought would be important to look for in any child who's born in Utah. And if they had any of these, either based on a maternal history of CMV infection during the pregnancy or any abnormalities on like circumference of the head, small for gestational age, abnormalities in imaging, abnormalities on transaminases, those should then trigger CMV testing. And this is in addition to the hearing targeted. And this actually was something that was really formulated from our group and then discussions with other providers. And you can see in this graph where 2013 is where we implemented hearing targeted screening statewide. And then we did a pilot program to look at a more expanded targeted screening and then actually implemented this through consensus among the neonatologists and other providers. You can see that there's been a marked increase in the amount of testing that was done. And this was all done without a state mandate. This is done without a law. This was done just because providers felt, based on the evidence, that this would be the best way to identify children with congenital CMV infection. And these are some of our results. We presented this. Some of this is published in our otolaryngology head and neck journal, as well as more recently, we presented this at the annual meeting of the American Otologic Society this past May. And this is just looking at about a almost 3-year experience where about 93,000 children were born. 9% of them underwent CMV testing based on the criteria that I presented to you earlier. 32 of them were found to be having congenital CMV infection. All of them were found to be symptomatic or had severe CMV disease. And then you can see that the most common reason for testing was actually for small for gestational age. 10 of them actually had failed their newborn screening. And so you could see that actually the majority of children actually would be missed if we just relied on hearing targeted screening. And so this really, I'd say about from a threefold standpoint, increased the number of children that we identified, and 15 of these children were treated with antiviral therapy. Now, how does this compare to these other approaches that I had mentioned, such as universal meaning testing every child who's born with saliva or urine, dry blood spot, which would be using the filter or the neonatal archived sample, hearing targeted, which was implemented in Utah in 2013, or this more expanded targeted screening approach that we implemented back in 2019. And so to sort of focus on the universal, this is the sort of the gold standard. This is where we would identify the maximum number of children with congenital CMV infection and also the number of children with CMV disease. If you compare that to universal dry blood spot, given that there's about a 75% or so sensitivity with dry blood spot sampling, which you can increase to about 85% if you use 2 different primers, which is what's being done by the Mark Schleiss's group, then you still miss a number of children with CMV disease, but again, you're certainly catching many more than you would if you didn't do any sort of testing. If you compare that to hearing targeted, unfortunately, hearing targeted really does not capture a lot of the children with CMV disease from this. But if you then go to expanded targeted, which is what we started in 2019, then I think the rates of CMV disease is pretty comparable to those with dry blood spot universal screening. Now, the big issue, though, is these kids with CMV infection. So, if you use a dry blood spot universal approach, about 300 or so children would be identified based on 100,000 births per year, and very much one or essentially no children from an expanded target would be identified. So, this is really the main difference. And the big question is, what is the impact of missing all these children? Now, the universal dry blood spot also has been implemented in Ontario, Canada, and Sharon Cushing has been very involved in this. And this is just a graph or a flow sheet just showing how they sort of accommodate or able to test all these children. It really involves a team of community pediatricians. Those that are found to have CMV disease or symptomatic are then referred to infectious disease, where they then will look at potential treatment, as well as they work with the audiologists and otolaryngologists for hearing testing. But this is a very daunting process for a large province of Ontario. And this is sort of the data just to show you. So the universal, this is again based on the Ontario group, where essentially 97% of the 500,000 plus children born in Ontario underwent CMV testing. Of those, they had 600 with a confirmed positive result, with 573 with infection and 34 with congenital CMV hearing loss. If you compare that to expanded targeted, during the same period, we had we had maybe half of those children. Utah, it's just one state, not a large province like Ontario, but you can see that the major difference is that we only had to test 5.3% of our 240,000 versus the 97%. So this in itself is a big difference in terms of the amount of resources and work required, not having to test all these children. And yet you can see that the numbers are pretty comparable in terms of those with congenital sensory hearing loss, though we definitely miss out on identifying those with CMV infection. So what is the impact of missing or potentially missing children with CMV infection? This is a study that's not been published that we're going to present at our CMV public policy meeting in Minneapolis in this fall, but it's a follow-up of about 2 years. All these children who had congenital CMV infection underwent diagnostic hearing testing before 3 months of age, and they all were defined to have hearing loss based on these criteria. And what I want to bring to your attention is that certainly those children who were found to have central nervous system or congenital sensory hearing loss at birth, about 17% of those children went on to develop progressive sensory hearing loss. If you look at those who had normal hearing but had central nervous system abnormalities, about 13% of those developed late onset sensory hearing loss. Now, these are the children that we tend to do well with expanded targeted screening. What is of interest is that we did identify some with CMV infection, and if we followed them for the 2.2 or so years of age, none of them went on to develop late onset sensory hearing loss. And so it seems like that based on the CMV severity that can be ascertained at birth, that can really help you determine the prognosis or likelihood of progressive or worsening hearing later in life. And there's a few other studies that I think are supportive of this contention. These are 3 studies. You'd think there'd be more, but there's really only 3 studies out there, which included brain imaging to assess for CMV severity. And they found a relatively low rate of children with CMV infection who went on to get late onset sensory hearing loss. Another caveat with these 3 studies is that they used criteria that I think, at least in Utah and the United States, we would not use. They looked at click ABR testing, and they looked at 40 decibels as their sort of criteria for hearing loss. Typically in the United States, we use tone burst frequency specific measurements. We also use EHL measurements. So we will calibrate our ABRs to what we have found, comparing it to normative data for hearing loss. And so I think with that much more strict definition, I think would have found that this rate would be actually much less. I'm going to now switch gears a little bit to look a little bit about dry blood spot, because we've talked a little bit about that. In Utah, prior to, I'd say, about 15 years ago, dry blood spot cards or filter papers were only kept for about 3 months. And so with a conversation with Harper Randall, we were able to convince the Utah Department of Health and Human Services to keep the dry blood spots for 7 years. And we have a paper that just got published in International Journal of Pediatric Otolaryngology this year that showed that we identified almost 20 children through this approach. With a yield of about 24%. The major reason for why these children underwent testing was for failed newborn screening, but they were older than 3 weeks of age, so we couldn't do the standard urine sample PCR testing, or they presented with idiopathic sensory hearing loss, again, at an older age. And the average age of detection was about 2 years of age, though we identified at least one child up who was almost 8 years of age. Every single child who had a congenital CMV infection that was diagnosed through this approach had asymmetric hearing loss, which I think is an important sort of consideration when you're seeing children who present to you with either congenital or acquired hearing loss, that you should really be very suspicious of congenital CMV if the child has asymmetric sensitive hearing loss. So to go back to this slide where we talked about the different approaches, at least our data and the literature at hand seems to show that if you have a child with a CMV infection, so they don't have central nervous system or other systemic manifestations of disease, these children are highly unlikely to develop late onset sensory hearing loss. So the question really is, do we need to identify all these children? I'm going to go back to the story of Caitlin just so that we sort of finish to, again, demonstrate the impact of congenital CMV and then finish off with some concluding remarks. I'm sorry, I don't know why you can't hear it because I can hear it pretty well. Let's see here. Maybe I'll see if I can turn up the volume. Would maybe that help? I'm gonna end my show, see if I can change the settings on my yeah, I'm gonna see if I can turn up the volume, see if that helps. If worse comes to worse, I can share my slides, and if anyone's interested, um they can also um listen to this portion. Let's see here. Can you hear it now? Okay. Okay. Well, I'm very sorry that for some reason that's not coming through. I think what I'll do then is I can share my slides and then I will just sort of finish my talk. So in conclusion, I think an optimal approach for early CMV screening is not clear. That I think there's still a bit of a controversy, though, there's certainly strong arguments for either approach. I think a universal urine CMV screening would be the best way to optimally detect these children, but there's significant hurdles with that would be a completely logistical challenge to do something along those lines. That a universal urine or dry blood spot, and then the question of dry blood spot CMV screening is that it may not be feasible for those institutions that don't have that resources because again, if you have 50,000 births per year in your province or in your state, that's a lot of work to test every single one of those children. And so I think an expanded target, in my opinion, it's not perfect, but I think it's a reasonable approach that will identify especially those with more severe infection. I didn't really talk much about neonatal and NICU children, but what we're looking at in Utah and in other places around the country is trying to incorporate either universal screening for those children, or at least having the children who are not able to undergo newborn hearing screening by 21 days due to their comorbidities, to have them undergo CMV testing earlier, and that also to consider dried blood spot testing for the older child. The video really was just to talk about Caitlin's story, that unfortunately her hearing continued to worsen to the point where she became profoundly deaf and required cochlear implantation. And so again, the sort of story for her has been ongoing, and that it's something that's been a challenge for Caitlin's family and for Caitlin herself. And I just wanted to highlight again the impact this has on our kids. I do want to acknowledge a number of people from our team. This includes the Utah Department of Health and Human Services. We have a translational team that includes pediatric neurology, infectious disease, audiology. I also have a basic science lab where we're looking at trying to identify the pathophysiology, CMV, and we have some really great data. I'd love to share with anybody interested. And then I also have a number of students, fellows, residents, postdocs involved in our work. Again, I'd like to thank you. I'd like to thank Dr. Mayorga, Dr. Carlos de la Torre, all the members of your societies for providing me this great opportunity. Thank you very much.